All right, so I'm going to talk about two studies which will have an impact. One of them already has been approved by the FDA. We're showing you some updated safety results and efficacy data from ASCO. Approved in January 2021 is Enhertu or famtrastuzumab deruxtecan. Is a HER2-directed antibody, which is indicated for locally advanced or metastatic HER2-positive GE junction or gastric cancer after failure of a trastuzumab regimen. So this is the final overall survival results. So this study had several arms. The one we're going to concentrate on today is the study population, which is HER2 positive, more than or equal to 2 prior regimens, randomization 2-to-1 between trastuzumab deruxtecan versus physician's choice, which was irinotecan or paclitaxel. So about 126 patients versus 62. These are the overall survival analysis. So overall with the Enhertu arm, the median duration of median survival was 12.5 months as compared to 8.9 months with standard of care, hazard ratio of 0.60. So you've all probably seen this already. And this was an updated analysis. This is looking at the overall response rate. So 61% in the Enhertu arm as compared to 8%. And on the right side is the waterfall curve. As you can see, the one in blue is from the Enhertu, and the one down is the physician's treatment of choice, which is typically chemotherapy with the taxane or the irinotecan. And you can see the responses there, and the waterfall plot showing significant responses in the majority of patients. The confirmed duration of response was 12.5 months with the Enhertu as compared to 3.9 months, again statistically superior. Progression-free survival number was 5.6 versus 3.5 months, p-value of 0.003, and a fairly brisk response, time to response of 1.5 months. The safety results are fairly similar to what we've seen in the breast cancer data that Edith and others have gone through before. The biggest side effects are myelosuppression, reduction in neutrophil counts was the biggest one, 12% grade 4 neutropenia. So again, we have to pay some attention to possible growth factor use or dose reduction, depending on the clinical setting. Myelosuppression with anemia, grade 3 anemia of 38% versus 21%. And finally, the one which I think is the most important to pay very close attention, since it's a very therapy-related side effect, is the lung side effects. So 12.8% of the patients had some form of lung side effects. 13 of them were grade 1 or 2, 2 of them grade 3, 1 grade 4. So there were 4 ILD events since the primary analysis, most of them grade 1 and grade 2. Median time to onset is the one, again, to pay close attention. It can be anywhere from 1 month to as late as 638 days, the average being about 3 months from the time of first administration. There was 1 death related from pneumonia, non-ILD, and there were no AE deaths in the PCR. So based on this, our conclusion is that it gives clinically meaningful overall survival benefit, 40% reduction in death rate as compared to standard chemotherapy. Side effects are manageable. Pay attention to the myelosuppression, and definitely the pulmonary toxicities. We're learning more and more as time goes along. We'll hopefully have more data on ways to manage this down the line. Most of them were grade 1 or 2. So the key is to pay close attention, and then dose modification or stopping treatment based on the severity of the side effects. The second one is a quick update on the overall. Sorry, we already did this. So next question is another one which will have an impact in the community on the treatment of esophageal squamous cell carcinoma. We've had a bunch of approvals of immunotherapy, chemoimmunotherapy in the adenocarcinoma. We've had some approval in the squamous cell, at least the NCCN guidelines, with a PD-L1 more than 10% with immunotherapy. Here I'm showing you data in the front line in patients with all comers. So this is the Checkmate 648 study. It's a phase 3 study of first-line Opdivo plus ipilimumab or Yervoy versus nivolumab plus chemotherapy. And these are the 3 arms. So fairly large study of about 1,000 patients, 320 patients in each arm. Nivolumab plus chemotherapy every 4 weeks. The second arm was the nivolumab, which was the chemotherapy-free arm, nivolumab plus ipilimumab. And the third arm is standard chemotherapy. The patients were stratified based on PD-L1 expression of more than 1% or less than 1%. region was classified as East Asia versus rest of Asia versus the rest of the world. All patients had reasonably good performance status, PS 0 or 1, and they were classified based on their amount of disease. Primary endpoint in this study was overall survival and PFS, and then they did do some subset analysis for patients more than PDL 1%. So this is the median duration of treatment in all arms. In the Nivo plus chemo arm, 5.7 months, Nivo plus EP arm, 2.8 months, and with chemotherapy, 3.4 months. And then down in the last box, you'll see the reasons for treatment discontinuation. 59% of the disease progression, and some of them due to the AE, which we'll talk in the next few slides. So here's the survival curves. On the left side are the patients who are PDL1 more than 1%. On the right side includes all comers. And on the left side, as you can see, the median overall survival starts splitting at about 4 to 5 months. And then you have splitting of the curve, and then it stays up to 27 months and then starts narrowing because of the follow-up duration. So in the Nivo plus chemo arm, median overall survival was 15.4 months. In the chemotherapy arm, it was 9.1 months. So about a 6.3 month improvement in overall survival, hazard ratio of 0.54, p-value highly significant at 0.0001. When you look at all comers, they're on the right side. That's the Kaplan-Meier analysis on the right side. Again, median overall survival in all comers, 13.2 months as compared to chemotherapy, 10.7 months. So a more modest improvement in overall survival of 2.5 months. Hazard ratio, again, of 0.74. Confidence interval is still within the less than 1 boundary. And the p-value still significant at 0.0021. This is the PFS analysis. That's the second. That's also a primary endpoint. On the left side, again, it's PDL1 more than 1%, and the right side is all randomized. So again, on the left side, we saw a 2.5 month improvement in PFS of 4.4 versus 6.9, hazard ratio 0.65, p-values again very significant at 0.0023. And on the right side, a more modest response again, an improvement of median overall survival, PFS very similar, 5.6 versus 5.8, hazard ratio 0.81, and the p-value was 0.03. This is the responses and the duration of response. In the Nivo plus chemo arm, we saw a response rate of 53% as compared in the chemotherapy arm of 20%. This was in PDL1 positive patients, so about a 2.5 times improvement in the response rates. And the median duration of response improved from 8.4 months as compared to 5.7. On the right side, again, when you see the all comers, the theme is very similar. The benefit is more modest. Response rates went up from 27% to 47%, and the median duration of response improved by about 1 month. This is looking at the arm of all immunotherapy versus chemotherapy alone. So this is Nivo plus ipilimumab. And again, on the left side, we have PDL1 more than 1%, and all comers on the right side. So again, with the PDL1 more than 1%, improvement in OS of about 4.6 months with immunotherapy alone as compared to chemotherapy, has a ratio of 0.64, again, a statistically significant result of 0.001. And on the right side, as you can see, a less modest response. There's a crossing over of the curve at about 7 months, and then improvement in overall survival, more modest, obviously, of about 2.1 months, has a ratio improvement of about 22% and a p-value of 0.01. PFS, again, very similar numbers in the all comers. In the PDL1, the median number did not improve. As you can see, the curve crosses over at about 7 months, which is below the 50% number, which is why the median did not change. However, when you look at the right side, there seems to be some prolonged duration of response, and hazard ratio is at 1.02, not statistically significant, so no meaningful improvement in PFS when you look at this analysis. And you look at all comers, very similar, no median PFS improvement, hazard ratio 1.26. And again, a crossing of the curve. Response rates, again, when you look at it, in the PDL1 positive patients, there's some improvement, 35% versus 20%. When you look at the PDL1 all comers, there's no improvement in the response rates, 28% versus 27%. These are the treatment-related adverse events. We have all come to expect this over the years. We're getting better at managing this. So typically you see the immune-mediated side effects when you use with the ipilimumab. So 32% any TRAE, and leading to discontinuation of about 13%. That's in the middle box. The one on the left is the Nivo plus chemo, treatment discontinuation of about 9%, serious TRAE of 18%. And in the chemo arm, treatment discontinuation of about 5%. So what we saw here was that the Nivo is the first PD-L1 inhibitor to demonstrate overall survival and duration of response with either chemo or AP versus chemo alone in previously untreated patients with advanced esophageal squamous cell carcinoma. This was observed in patients with in all comers and more pronounced in patients with more than 1%. And there's a clinically meaningful PFS benefit and a higher overall response rate with Nivo plus chemo. And there were no new safety signals that we saw in this trial. So I think I'm going to stop here.